Hello, everyone. Today is February 9th, 2023, and we are back with another Sagely Health webinar. Today, we're going to do something a little different, and I think we'll try and do this again in the future, but we're going to do some real-world case studies. We talk a lot about general cancer types, or we talk about next-gen sequencing, but we really know that every single case is completely unique. And we also want to highlight the Sagely Health approach to helping cancer patients. So what we'll do today, I'm joined by Dr. Sager, as always, founder and CEO of Sagely Health. And today we're also joined by Lauren, one of our patient advocates. Lauren will introduce a case, and we'll talk about how we approach their case, how we get the details, how we do our research, and kind of how we think about approaching a treatment strategy for them. And then because these are cases that have a little bit of distance, we're able to kind of update you at the end on how these cases went, how these patients are doing. We're keeping everything anonymous, but these are real cases. So with that, Lauren, I'll turn it over to you. What's our first case today?
So our first case is a 73-year-old male who initially presented with prolonged sciatica pain. He had a lumbar MRI performed, which revealed a large mass in the left kidney, which was noted to be the suspected primary site of the cancer. And it appeared to have widely metastasized or spread throughout the body. The patient also had a brain MRI at that time.
All right, so Jason, do you want to, I don't know if you're going to share your screen or anything, but do you want to kind of walk through how you start to approach just that information?
Yeah. You should be seeing the screen, and let me just bring up a fresh case here. There we go. And so, what we generally do at Sagely Health is we'll start putting in some of the details. You mentioned that this patient, I believe, was 75?
73.
73. And the patient's a male. And we oftentimes will denote sort of what sort of health this patient's in. And this is a system called ECOG. I don't know that we really got enough information to answer this, and that's okay at this stage. Did you mention where the patient lives, or do we know where the patient lives? Because that's something that as we do this, certainly would be helpful.
Yes, so Virginia and the DC area more generally.
Okay, all right. And so, so we could do this one of two ways. Oftentimes, I like to start by looking sort of in the region that the patient's located, and you said Virginia, so we can select on the South Atlantic region, and then kind of go from there. We can actually add a location here, and so you had mentioned the Virginia area,
yep,
something like Falls Church, perhaps.
Yep. Mm-hmm.
All right, and so we'll put that in, and then we move on to the cancer type. And here we said it was kidney, which is also called renal cell carcinoma. And when we do this, a number of traits come up that we have sort of pre-selected for. You mentioned the first one, and almost in all cancer cases, what we look for is what the stage is. And just remind me, I think you had said the stage was widely metastatic, yes?
Yep, stage 4 metastatic.
Yeah, so stage 4 is metastatic, and so we'll click on that. Do we know what the histology is? And the histology will frequently come from a pathology report or something like this. The most common one is called clear cell, but there can be a number of other ones, and our system is sort of trained for all of those.
Yep, so the patient had a cytology report rather than a pathology report, but it did reveal clear cell histology.
Great. And we have a risk for recurrence here. We'll put this in on high risk. And the stage 4 details, there are multiple different varieties of these. This patient has multiple metastases outside. And this includes it sounds like the lung, the liver, and the bone. Did they happen to see the adrenal glands, and were they clear?
It was not noted on the CT scan as far as...
You may not know this. Yeah. So we can take a look later. For now, we'll presume that it's not there. I don't know that it would really make a difference in this situation. And likewise, I'm going to skip over a few of these because they really no longer apply. And we get down to our solid tumor. Now, this patient's never been treated before, as far as we know, and so we won't put that it's recurred. Certainly has measurable disease, and it sounds like it's really inoperable at this point, in the sense of operating for removing all of the tumor in the body. Although we'll get to whether or not the kidney should come out or not, that's a sort of a fine point of discussion, but that's really not going to expect to get all of the cancer out of the body. Not progressed. It seems like the patients had no prior systemic treatment and no prior surgery, no prior radiation. And this is because the patient is metastatic. This would be for first line patient, first line of treatment. Okay. And so we can go ahead and do a search based on this. It takes a few minutes to come up, or a few seconds, I should say. Sorry, Jeremy. But here we have 22 therapies that match. And so we can start to dig into what these therapies are. But, perhaps before we do that, I always just take a look to see, are there genes that are dependent upon this search? The answer is no. Any diagnostics? No. There's a bunch of patient characteristics, which can get into some of the finer details. We'll come back to this in a little bit. There are prior therapies that may be important, although I expect that most of those will be he hasn't had them. And then there's some concurrent treatments that will be important to consider. Having looked at these before, we know that there's a number of various therapies that can be utilized in this situation. What's important is that the first thing is that there are several that can be selected from. There's actually several standard therapies. Those include things like cabozantinib and nivolumab as one. In addition to that, we have there is lenvatinib and pembrolizumab as a second one. And then there's a new one that is actually being tested here, which is called ipilimumab and nivolumab. The very interesting thing is that ipi-nivo, as it's been come to be called, is strictly immunotherapy. So nivolumab is immunotherapy. Ipilimumab is also immunotherapy. And what they're looking at here in this trial that I'm showing is that they're combining these two to try to do better. Now, already we know that immunotherapy works, and it also works with chemotherapy. And so the cabozantinib is a chemotherapy. It's actually a TK, what's called a TKI, a tyrosine kinase inhibitor. And nivolumab is immunotherapy. Combining those together already works quite well. And we'll dig into a moment how well they actually work in a second. But what this trial is testing is whether ipi-nivo is working any better. And what you can see is when I look at where this is located, up comes Georgetown, which is literally 6 miles away from Falls Church. And so when we look at all of these, and I can sort by distance, we'll see probably that this trial, amongst a few others, are coming up really, quite at the top of what would be available. And you can see there's actually quite a number of possibilities, which is generally what we find. In this case, 22 possibilities just in that one region to take a look at. But certainly, from my perspective, having seen this before, this would caught my eye. And I said, well, this could be, quite interesting. Who is working on this? And so, let me just pause to see if you have any questions about that, or, and then we can talk about sort of what we do next.
Well, Jason, could you explain what you mean by standard? In the sense that I think what you were saying about this trial you pointed out was this takes the standard and adds something to it. But how should a patient understand kind of what's standard versus what's not standard?
Yeah, that's a great question. And, from my perspective, standard of care is what, when a patient goes to the oncologist, that's what they're going to be hearing about almost 97% of the time. I say 97% because we know 3% of patients get onto clinical trials. Clinical trials, like we're presenting here, are really built to try to do better than the standard of care. And oftentimes they'll use the standard of care and add something to it. Sometimes they'll actually try to go head to head with the standard of care. Again, not blindly, but with something that's already been shown to work. And what they're asking this question is, can we replace the standard of care with something new? So there's a variety of ways that these clinical trials work, but it's all compared to the standard of care, which is sort of the oldest version of what we know works. It's not necessarily the best version of what we know works. And so from my perspective, it's always advantageous to look at the clinical trials, especially if the patient's at high risk, such as in this case where the patient has metastatic disease. I think clinical trials are always going to offer the best possible treatment to get the best possible outcome for the patient. We can dig into this trial and take a look at it. We have our own way of sort of, having characterized the trial, and we can take a look at that. In addition to that, and you can see that we have references as part of this, and we can actually take a look to see, how well did this therapy work? How well does the standard of care work? What are we looking to do better with? And as I could say, these trials don't come from nowhere. They're built on a history of either other trials or very, very sound scientific hypotheses that have been reviewed at the FDA level as well as the local hospital level. And so there's a lot of work that goes into these. And so if we take a look at a few of these results, we can pull up the reference. And now I'm showing you the actual paper that is in the PubMed sort of national library. And we can take a quick look at this and say, okay, well, how well does this work? And again, these papers are written in a fairly complex way, but again, this is what we do. We look at these and we try to figure out sort of how well do these therapies work. And so if you look, I think there's really, two very important parts of this. One is to look at what we call the median overall survival. This is how long patients lived when they were getting this therapy. And the answer is the average was 37, almost 38 months. That's a long time. That's like more than 3 years. So that's exciting to me. Rarely do we have patients who, have, widely metastatic disease where we say, yeah, and basically we've got a treatment that's going to work for 3 years or better. And I say or better because remember, what we're trying to do is to find clinical trials that are going to try to beat these numbers. And so, I think that this is actually, despite the severity of the situation, I think it's quite hopeful for the patient. The other thing that I like to look at is the what we call the side effects, called adverse events in scientific lingo. And specifically, we're looking at severe or life-threatening side effects, and they are graded from 1 to 4, and this would be grade 3, 4. And again, these folks who are writing this up know what they're talking about, and so they address it specifically. The grade 3 or 4 events were about 13% versus 12%, 8% I see. So, again, those are all decent numbers, right? That's 1 in every about 10 patients who's going to have a severe event, which means that 9 out of every 10 is not. And again, it's sometimes hard to differentiate what's being caused by the cancer versus the medicine. So I'm encouraged by this. And from my perspective, this would be a fine, therapy to start with. And this is why it's likely standard. That being said, we can also take a look to see what does it look like for the other side, that new therapy that's being tested. Again, there's literature for it, and we can take a look at that as well. Let me just ask if you have any questions on this before I jump into the Ipi-Nivo combination.
No, just to be clear. So when a patient comes in, you're looking at the standard care that they're likely to be offered by their oncologist and kind of trying to understand. And that's what this reference is for. If they go with this particular standard of care, this is kind of what they can expect from it. And so now I'm kind of curious, how are you showing data about a clinical trial that's in progress or available now if it hasn't completed?
Yeah. Yeah, and recall that as I bring this up, that that not that these clinical trials have predecessors. This might be a phase 3 trial, and so what I'm going to be looking at is the results of the phase 2, sort of the trial before that. But again, these are all built on something. And even the ones that are phase 1 that have no prior experience are built on scientific data and rationale. And those are reviewed by lots and lots of folks, and take millions and millions of dollars to actually invest in. So people are trying hard all the time, but we're able to basically comb and make sure we find any data that's out there. So it could be a handful of patients, it could be hundreds of patients, or even thousands. That being said, we'll take the data and try to do the best that we can to understand and prioritize which are the therapies that are going to be best for this patient to get them the best possible outcome.
Yeah, I asked the question because I think there can be a
Does that make
misunderstanding
sense?
about Yeah, I think there can be a misunderstanding about trials where they feel extremely experimental. Oh, we're just going to try this drug, and I just kind of wanted to highlight that, like you said, with the phase system, with kind of the targeting nature of many trials, there's strong evidence and data to support even running the trial. It's not so. I just say that's what we're using a lot of, is to say, like, what is the available data out there, because it's out there.
Yeah. And already, like, kidney cancer is one of those cancer types that I think we've done fairly well with. As you can see, 3 years of, for just one therapy starting off with and then trying to do better. I mean, and the fact is, we haven't even talked about the traditional chemotherapies, those drugs that cause the hair to fall out and lots of nausea and other things. There's still side effects to these medicines, but clearly this is an arena where the world is really doing well and trying to even do better. And so it's encouraging to me as an oncologist to be able to offer this to patients when it exists. And so let me show you the other trial. And again, this is a publication, probably an earlier publication in terms of, though this is a phase 3 trial, but again, this may not have been the one that they were trying to replace the final therapy, or this may be a different version and they're doing a phase 4 trial now. Whichever it is, we can take a look at those results. And here it's really interesting because when we dig into the findings, now that I can get to them, you can see things that, the comparison was 26.6 months. Remember, before we were looking at 38 months, something like this. But when we actually look at the Ipi-Nivo arm, they followed this for 33 months, and they didn't reach a median, which may be why they continue to enroll the trial and watch for it, because which means that more than half the patients are going to be going for more than 33 months, which is very encouraging. Now, this is an earlier trial than the one that we looked at previously. So we don't quite know yet how it will compare based on this data, but already it looks quite encouraging. And, this is a study that we will follow along. As we do that, we'll also take a look. Now, remember, the other thing that I like to look at are the side effects. And Ipi-Nivo has a tradition known to have a decent amount of side effects. That being said, in this trial, you were seeing that, basically they don't give the total grade 3-4 events as far as I can see here. But what they do is they do break it down. And you're seeing things like 6%, 10%, 5%, 17%. But that's hypertension, high blood pressure, and medicines can be used there. So there are definitely side effects to this. And, they seem like they're in somewhat of the same bucket as the other. So, when it came down to it, even though I'd say, this is a newer therapy and quite interesting, I don't know that there's a favorite, I would be fine with either one of these for the patient. And so let me just stop there. Do we know, what happened to this patient, Lauren?
Yeah, so we actually prepared a report for the patient with those therapy options that you just detailed, along with a couple other trials at Georgetown, that were kind of back burner options. And then the patient went for a consult with the trial investigator, who is a physician at Georgetown. And based on that consultation, the physician opted to treat the patient with the cabozantinib and nivolumab combination. And so the patient's been receiving that for a few months and is doing very well, and also received a short course of palliative radiation to relieve those symptoms of pain in his right hip.
Excellent. Excellent. Yeah. So that, to me, that is exactly why we do this. I think it's important because patients will, might watch this and say, well, the patient just got the standard of care at the end of the day. And the answer is yes. But in the setting of someone who has something else to offer, to me, that's the important part. Because many times, if you go to a doctor who doesn't have a clinical trial, you'll never find out whether or not that clinical trial is the best thing for you. And so to me, the best thing we can do is to get the patient to that doctor. There's another benefit, which I want to talk about, because the doctors who are running these clinical trials are really expert. And what we know from this patient that we've shared previously is that we know that this patient was really comfortable with this new doctor. And so even though the patient ended up on the standard of care, that's fine. But with a doctor who's really got depth of expertise and doesn't, by the way, just have that one trial, but has multiple other trials. And so if and when that, cancer should come back or grow, or another trial should be out there to do better, this doctor will likely know about it, be able to inform the patient, and the patient can get on right away. And so all of these things are benefits that I think you don't generally get by just going the route that the system sort of shuttles you down. And that's why it's really important to find doctors who have clinical trials and get to ask one, usually in the form of a second opinion, and evaluate whether that trial is right for you and whether that doctor is the right one for you.
Yeah, I'm struck by the timelines and being close to the source. And because you're pulling up data that's looking over at like a medium survival rate, and you're like 3 years in and they're still measuring it. So that's good news, because that number, if it continues as it kind of is going to beat the standard. But the FDA hasn't said that it has yet. But the guy running the trial, or the woman running the trial, they know. They understand, so they can kind of make good decisions with the patients that they have ahead of it, because the trial, like you said, the trials, oftentimes something people may not understand is when trials are working, they often continue to recruit. And so it's something where there may be data showing that trial is there. So just kind of shifting this particular patient's care to someone who has these trials in their orbit and has know-how about them, I mean, you can see the difference it can make. And they took the standard treatment now, but we all know recurrence is a risk, and especially, with metastatic, it's almost guaranteed in some cases. So, yeah, I'm glad you were able to highlight that.
Right.
And
from talking to the doctor, that the doctor actually looked at both and thought that this Cabo-Nivo worked a little bit faster onset, given the fact that the patient was already having pain, wanted to start with this, even though the doctor is very excited about the trial for the Ipi-Nivo. And so, in the end of the day, just wanted to, acted on the patient's behalf, which is what we always do.
Yeah, that's great. So let's jump to another case. Lauren, what else do we have today?
So our second patient is a 57-year-old female who initially presented with hair loss, 20-pound weight loss, but she believed that was due to some personal issues, and so delayed her colonoscopy and symptom assessment as a result. The patient also notably has a history of irritable bowel syndrome and is currently experiencing bowel problems such as rectal urgency, abdominal cramping and aches, and blood in her stools. She finally had a colonoscopy done, and it revealed an obstructing mass found in the mid-rectum.
Get out the screen again and share. Just give me a moment here, because this sounds like, again, from what I heard, it was a rectal cancer patient. Do we know anything as I do this about, the extent of her cancer? Has she had a CAT scan that has shown any masses and sort of where things are located?
Yep. So she's had a CT scan, which revealed that it was rectal adenocarcinoma. It's about 6 centimeters in length with 4 to 5 suspicious lymph nodes. And so as a result, they did staging on MRI and reported that stage to be 3B, so T3, N2A, M0 for the specific tumor, lymph node, and metastatic staging.
Great, great. And as we do this, one of the things that we do is we look at what that staging is. It's nice when it does come with that sort of stage 3C, but as you mentioned, there's a bunch of other letters and numbers in there. And just to show folks, this is all based on something called the AJCC. It's an organization that basically categorizes all of these tumors, and I'm on page 177 of a 672-page compendium where they actually go in and talk about each of the tumor types. And I pulled out the rectal cancer one here, and you could see the steps that you would go through in looking at the tumor size and how its depth of invasion, the lymph nodes, and you mentioned I think 4 or 5 right in there, and 2A, and then whether it's distant metastatic or not, and that's the M, and it sounds like it's M0 right now, which is great. So then you compile all these into that stage. And again, we heard that it was stage 3. I believe you said C, yes?
B.
Yeah, B as in boy. Good, excellent. So yeah, so we're right in here. And so as we go over to our system, we can now take a look. And by the way, I also wanted to just share with you that when I was looking at this, for this patient, the American Cancer Society actually has a nice page about, colorectal cancer stages, and, goes through and tries to make it a little bit easier for folks to figure out what it is. Again, it's nice when it's given. And I always encourage patients to ask their doctor, what is my stage? Because again, it's really important. So now as we go over to our population search, remind me the age of this patient?
57.
Okay, woman. And again, we'll assume it sounds like in good physical condition. Did you mention a location?
Franklin, Massachusetts.
Okay. And so again, I'm going to go to the region and just take a look at the New England area to start with. And we'll say Franklin. Oh, that's Alabama. Here we go. And now we'll take a look at some of the cancer types. And so we said rectal. And we said stage 3. B is in boy. Do we know anything about this patient's tumor sequencing? Because I'll tell you why in a second, but this prompts me because I see this MSI, MSS.
Yes, so they did have mismatch repair testing, and it revealed that her status is microsatellite stable or MSS.
Okay. And then some of the other common genes that are found in rectal cancer includes RAS, frequently KRAS, and BRAF. Are either of those pointed out in the report?
Those are wild type on next-gen sequencing. So yeah. No mutations.
Okay. So we can put that in wild type. Yep. Perfect. Great. And then we can go, and I guess one other question, do we know about the position of the rectal cancer, low, medium, or high by any chance?
It says mid-rectum, so medium, I would assume.
Oh, okay. Okay. Yep. Sounds good. And again, the reason that that's important is really the type of surgery that might be involved. the closer to the endpoint, the sphincter, you get, the more problematic the removal of it could be in terms of influencing the patient's ability to have regular bowel movements and that sort of thing. All right, so let's go and say advanced. I would put this in the stage 3 arena. Certainly measurable. I would say it is operable, but perhaps we hold off on that just to see if there's something that we can do to put this patient into better situation. This is not progressed. The patients had no prior treatment, and we're looking for. So here I would say likely we're looking for something like neoadjuvant as well as definitive treatment. And so we can do our search based on this. And we get 13 therapy matches. And again, I see right away as this loads that there's actually several genes. We talked about some of them already. And so we know that this is not BRAF. We don't know about EGFR, and HER2 amplification is going to be very interesting here. But we know the KRAS is negative. And do you know the status for these other, for HER2 by any chance, as well as EGFR?
They weren't noted as coming up with any positive or special results.
Okay, and we can leave them blank for the moment and apply these changes. Okay, we also see that there's some diagnostics here that come up, and for the VRAF, it'll be negative. For the MSI, you mentioned that if this is not highly unstable or positive. And again, this is really an important point because there was a study a while ago, not a while ago, actually quite recently, that where they tested patients with this special sort of MSI high. It's about 10% of rectal cancer patients. It's actually quite, the MSI high can happen in every cancer type to a various extent. And so this is one of the reasons that we always recommend having MSI and having tumor sequencing, because MSI will come with it. And we can find that out. Had she been MSI high, we would direct therapy in an almost completely different way. Instead of using some of the chemotherapies, we would switch over to that immunotherapy, like we talked about for renal cancer. For colon cancer, we know immunotherapy and rectal cancer, it doesn't work so well, except when you have this MSI high. And actually, I did pull out the paper. Let me just see if I can find it quickly here, if it still exists. Yeah, here it is. What they found in this paper that we've reviewed in previous times is that patients who got treated with rectal cancer in this MSI high, they had 16 out of 16 complete responses, meaning the tumor completely disappeared. And so from my perspective, that's really fantastic. And what it means is that we should really look at every patient and their tumor sequencing to make sure that they get that, even if they only have a 10% chance of having it. If you have it, it's really incredibly special and treatable. And so that's the sort of thing that we want to make sure is brought to the table. Knowing this patient, we know that the patient wouldn't have had tumor sequencing until we came along and recommended that they have it. And so for any patient with high-risk cancer, please ask your oncologist to get tumor sequencing, called next-gen sequencing. It's called a few other things, but basically if you ask for that, it should be provided to you. So one of the things that we know is used in colon cancer and rectal cancer is something called FOLFOX. And I'm just looking here to see, but FOLFOX we know is the standard of care. We can find this in American Cancer Society, the organization called NCCN also has it, and we have it also in our system, so we can pull that out and reference that. We know that it does fairly well in reducing the tumor size so that it can be operated on. what we're looking for here then is to see, well, are there things that can be doing better? And, you can see here, there are various other trials going on, some of which are combined with FOLFOX, some of which are combined with something called FOLFIRI, which is similar to FOLFOX with one difference in chemotherapy agents. And here there are drugs being combined with this. And again, they may be quite close to the patient or they may be a little bit further away. And if we look at sort of the entire situation where, what's out there, we can see that, there's a number of trials that I think, we could direct the patient to find out about. We can also take a look a little bit more broadly and say, let's just take a look across in the entire region and, see, is there anything going on that's, particularly special? And I'm looking at the entire country now and pulling out everything that's going on there. And, up come 49 therapy matches, which is quite nice. We have a nice feature here that we can dive in and take a look at a map and see exactly where these are. So I think before I was looking in the Boston area and certainly interested in sort of what's in here, but there's also a bunch in New York. There's some in upstate New York that could be within reach. And, we've built our system so that we can dive into any of these at any point in time and take a closer look. So now just going to sort of look at, what's going on out there, we again can say, okay, let's sort this by most relevant. And, remember, the one thing that we'll make sure she's been tested for HER2 because there are targeted therapies that are going against HER2. In addition to that, here is a trial that is working with adding something to that standard of FOLFOX chemotherapy. And so, again, there's a number of different avenues here by which, sure, it would be already good to get the standard of care. And we have the potential of even doing better by directing patients where, especially if these trials are close to them, we can match them and get them on these trials that have the potential of doing better. So let me just pause to ask if there was any questions on this case and maybe some follow-up.
Yeah, I mean, I'm impressed by how complicated some of the details of this are. So I mean, I can just see how someone could get quite lost quite quickly. I'm trying to kind of research this sort of thing online. And I don't want to say, so this patient came to us, and I'm also struck by how targeted a lot of these treatments are. When you're talking about the gene mutation, that's what qualifies you. So when this patient came, I think you said they had not had the MSI tested, they had not had the next gen sequencing done. So that's something that we helped them do. And so, because these trials, these would be requirements to even be considered for these trials, right?
That's correct. That's correct.
Okay, so what happened with this? What ended up happening with this patient? Did she go to these trials or what? Lauren, do you have any update on her?
Yeah, so the patient ended up meeting with radiation and medical oncologists at Dana-Farber Cancer Institute in Boston, and they recommended neoadjuvant chemoradiation with capecitabine, followed by FOLFOX or FOLFIRINOX. The patient so far has experienced no major negative side effects except for some fatigue and some pain and overactive bladder due to radiation, but those are well managed with medication. And she did have some issues. She ran into some issues with the insurance coverage of the next gen sequencing, which we were a bit surprised about, but we do have some prior expertise in appealing those denials. And so we've been working with her to get that covered. And we would be using actually that paper that Jason was referring to that recently came out about the 10% MSI high status as a rationale for why she needed to have that done, because it likely would have changed her course of treatment.
Yeah, absolutely. And one thing I'd say is we're non-judgmental over here, but I think of the beginning of this case, you kind of talked about how this patient had a number of symptoms who had kind of equated them to some things going on in her personal life and did not get checked. So this is a case where I just underline that, if something's going on, get yourself to a doctor, get it checked out, because with cancer, if it is, and we hope that it's not, but if it is, the earlier, the better for understanding your diagnosis. And Jason, with that, anything else you'd like to add about this particular case or anything overall?
Yeah, no, I hearken back to the sentiment, and I agree. It's complex. Cancer is complex. The therapy is complex, and unfortunately, the system is also complex. And so, for patients who are diagnosed, I think there are steps that they can take to do their best. They don't have to be a trained oncologist, because the fact is, there's a lot of us out here ready and willing to help cancer patients. That being said, they need to come and be proactive, to find advocates, to get family members who can help them, to look for clinical trials and talk to people. We know Colon Town is a source for colon and rectal cancer patients, where they are able to help navigate the system. There's Cancer Commons. There's a whole bunch of us out here, and we're available too. So, we have ask a question on our website, reach out to us, and we're here to help. We do, help patients to get second opinions, and we will engage with patients in a concierge way. But, we try to make ourselves accessible to as many as possible, and to make sure that the basics. What can you do to really take advantage of the system and put it to work for you, such as getting tumor sequencing? And you don't have to know about how it's used to know to ask, can I have my tumor sequenced? And so in this case, it's really important. And we were a bit shocked that the insurance company wouldn't pick it up. It's something that we'll be working, as well as many others will be working to try to change that in the future.
All right. Well, I think that's probably a good place to end it. Thank you, Lauren. Thank you, Dr. Sager. And thank you, everyone who is watching and everyone who watches this video later without this major delay issue. And we'll be back with more case studies in the future. And I just want to point out that, as Dr. Sager said, if you have questions, if you want to get your case assessed by Sagely Health, we are available at sagelyhealth.com. All right. Take care, everybody.